Hi, my name is Dr. Robert Traeger. I'm a chiropractic physician at university hospitals, and one of my main interests is treating sciatic pain, and that's what this talk is about. Little disclaimer, nothing in this talk constitutes direct medical advice. Please discuss any information with your personal physician. A little disclosure that I've authored a couple of books on sciatic pain, and I will be showing a couple of anatomical images or cadaver images. So if you don't want to see that stuff, maybe turn away when I show that. All right, so what is chiropractic? My brief definition of chiropractic is that chiropractic is a portal of entry conservative care set of providers that focuses on musculoskeletal conditions. And we tend to focus on conditions of the spine and use hands-on therapies for treatment. Uh, this collage of images shows that a lot of what we do is diagnostic. It's not just limited to treatment. And we also have training in nutrition, home exercises, rehabilitation. We can look at images. It's not all just cracking and popping. We do hands-on soft tissue work, kinesiology taping, all kinds of different hands-on, what we call manual therapies. Where do chiropractors fit in the integrative model, in the healthcare model, and for us, the hospital system? I believe that chiropractors often co-manage their patients with the other healthcare team in order to best benefit the patient. And that's how I view myself in the hospital system. We co-manage our patients with primary care, physiatry, ortho, neuro, all of these different types of providers, including physical therapy, in order to get the best outcomes for our patients. And that includes patients with sciatic pain, because oftentimes these patients need a comprehensive treatment plan. Some of what we do is diagnostic oriented, some of it is treatment oriented. So there's a broad spectrum of what we do as chiropractors. There is some difference between chiropractors and physical therapists, but I think overall there's more in common than there is different. For me as a chiropractor, I feel that I focus more on pain relief, and we dabble in the rehabilitation and the exercises, whereas physical therapy, that's where they excel is with the rehabilitation and giving people exercises, walking them through exercises. And oftentimes we work together and we refer patients to physical therapy. If you're a provider watching this, thinking about should I send a patient to a chiropractor or a physical therapist, you can actually do both. I mean, you can send the patient to both, or you can leave it up to them and let the patient decide. And when we treat a patient with sciatic pain, we do what we call a trial of care. I mean, we don't exactly know how many visits the patient will need. So we start off with a handful of visits, see how things go, and then decide from there. What is sciatica? So sciatica is a very broad term. It's almost like saying that you have a headache. It's really just telling us that there's pain or sensory symptoms in the distribution of the sciatic nerve or along the course of the sciatic nerve. And the sciatic nerve is the longest, thickest nerve in the body. It runs down the back of your thigh, deep down in the thigh. And you can see that in this picture, I mean, everything in this picture would technically be considered sciatic pain, but they're all a little bit different. So on the top of the screen, we have the sciatic nerve. We have referred pain on the top right. And on the bottom of the screen, we have what we call radicular sciatica. And that's sciatic pain that follows the course of a nerve root distribution that originates from the lower back. And patients don't necessarily have to have just one of these things. There can actually be a blend of things. So sciatica, very broad. There's a lot of things that can cause it, and it can present in many different ways. This is a drawing of where the sciatic nerve goes on the left image. It runs down the back of the glute, the thigh, and splits into two nerves, the tibial and common peroneal at the knee. And along this course, it's susceptible to injury. The nerve trunk itself has pain fibers, nervi nervorum, that can sense pain. So if you injure your sciatic nerve, you can feel it. But just a very, very big nerve with a broad distribution. Sciatica has been known about for thousands of years. Since the beginning of recorded history, we actually have examples of sciatic pain. And the top image is preserved mummy named Uzi the Iceman, who was found in the Italian Alps in a glacier. And he's 5,000 years old. And researchers have been studying him for decades. And some of them have come to the conclusion that he was suffering from sciatic pain based on the fact that he has tattoos in his lower back all the way down the sciatic nerve distribution. And along with some of the things he was carrying in his pouch, some of the x-ray findings, radiographic changes of disc issue, potentially SI joint issues, they came to the conclusion, okay, maybe he was treating it or getting treated for sciatic pain with some early form of acupuncture, or what we call moxibustion. And then on the bottom image, we see what we call a sciatica amulet, which was supposedly a pretty popular item to have on hand. This is from about 500 CE, and people would supposedly hold these to ward off sciatic pain. And the image typically depicts some kind of manual labor. In this image, it's a reaper, and he's bending over, cutting grain. And back then, the Greeks and the Romans felt that sciatic pain originated from the hips. So that's where the word sciatica comes from. If you know the bone that you sit on, the ischium, the word sciatica actually derives from that. And so they felt that the sciatic pain originated from overuse of the hips. And they weren't completely wrong. It's actually an interesting idea that comes to modern day. However, in 1934, two medical physicians from Harvard University did a large study on cadavers and patients where they were doing autopsies and found disc herniations in the lower back. And they were the first to really bring together a big study on this. So they're credited with discovering the disc herniation. And as we know, in 2020, disc herniations are the most common cause of sciatic pain. It's not 100%, but it is the most common cause. And when these two physicians discovered it, it refocused everyone's attention on the disc as a trigger of sciatic pain. And before that, there were all different ideas as to what triggered sciatic pain, including, like, we go back to the Greek and Romans, they thought the hip was a trigger. So this is a chart showing the most common misdiagnoses in sciatic pain. And I like to show this because going from the ancient times up till modern, we've shifted from the hip to the spine, and now we're kind of going back in the other direction a little bit. In this study, the authors found 239 patients that had severe sciatic pain that was not treatable with their current treatment plan, and they ran them through a battery of tests and did MRI on the lower back, MRI on the pelvis, diagnostic injections. And what they found in these patients, they call them the misdiagnosed patients. The most common misdiagnosis was what they call piriformis syndrome. And we typically call this deep gluteal syndrome now because it's not just the piriformis. But the main message here is that the lower back is, although it's the most common cause of sciatic pain, there's this other kind of neglected category in the gluteal region related to some of the muscles. And the other one is ischial tunnel syndrome. And you can see some of the disc-related things, the stenosis. Those are actually very rare to misdiagnose. This is the big picture of the causes of sciatica. It's a bubble chart. The size of the bubble is proportional to the cause of sciatic pain. Lumbar disc herniations, that's according to this top study on the top right, about 55% of patients with sciatica. Lumbar spinal stenosis, that's another 10% or more. So we have 2/3 of patients, at least, with sciatic pain related to things inside the spine, namely lumbar disc herniation and lumbar spinal stenosis. And we have this other group in the gluteal region related to the muscles. And then we have those smaller dots are all about 1% or less. And I don't want to scare anybody by showing them this, but occasionally we will see this as providers. We will see things like these infections or tumors that come on. It's very uncommon. And the vast majority of people have a spinal issue or a gluteal issue. Lumbar disc herniation, or as we put LDH, is the most common cause of sciatic pain. In the picture here on the left, we see a large disc herniation. And as it comes out of the spine, it can hit one or more nerves that are descending through the spine. And you will often get that radicular pain pattern shooting down the leg. And very painful. It can trigger weakness, numbness. On the right image, this is actually the same patient a few years later. That disc herniation went away. The patient actually came in for a new onset of back pain, so they got another MRI, And it turns out they had a problem with the disc below the other one. So this is really interesting sequence of image because there's been two big studies that came out recently, and they both showed about 2/3 of disc herniations will shrink in size or go away over time. So that's what they call spontaneous resorption, spontaneous regression. But the majority of disc herniations will actually shrink or go away a little bit over time. So it actually has a relatively good prognosis. And sometimes the bigger, more scary looking ones are the ones that actually shrink the most. This is an example of lumbar spinal stenosis on the bottom. The top image is actually a normal without stenosis, but all lumbar stenosis refers to is a narrowing in the spinal canal. And that's the tube where the nerves descend through your lower back. So in the top image, we're looking down that tube. The white is the cerebrospinal fluid, and that is the fluid that our nerves basically bathe in. Those black dots going through there are the nerves. And on the bottom image, we can see this space is much more narrow. It's actually kind of a triangular shape. And what I'm measuring here, this measurement is the ligamentum flavum. It's the ligament on the back of the spine, this thing right here. It's supposed to be very thin, but in some patients it thickens and it takes up space in the lower back here where the nerves come through. And so that's just one of the triggers for stenosis. There's other things. Some people are born or develop with a smaller circumference of their spinal canal, so they have congenital stenosis. However, with ligamentum flavum thickness, that's one of the things that we see. It occurs with instability of the spine, obesity, metabolic disorders, things like that. It's one of those things that trigger sciatic pain. It's one of the top causes of sciatic pain. And this is that neglected category I was referring to. This is what we call a deep gluteal area. Everything in that dashed line is the deep gluteal space. And so this is autopsy or a cadaver. Basically, you're looking at the left gluteal region. If you just imagine the person lying face down, we're looking at the left gluteal region. And in this space, number one is the sciatic nerve. It's as thick as your index finger. Number two is the piriformis muscle. That's the muscle that actually gets a lot of blame for sciatic pain, when in fact, anything in this dotted line can trigger sciatic pain. You can fall on your glute. You can strain a muscle with a sporting injury. You can sit on your wallet. You can go on a long car trip, a long plane trip. Any of those things, you can get a spasm in the muscle, inflammation. You can get any sort of injury to this area can trigger sciatic pain. And another one is number four, that's the hamstring. So the hamstring is right next to the sciatic nerve, and hamstring tendinopathies, hamstring strains or tears can trigger sciatic pain. And then the roof of this space is the gluteal muscle. So the gluteus medius, gluteus maximus, those muscles can actually kind of tighten up and potentially trigger sciatic pain as well. This is a hurdler who developed sciatic nerve symptoms, and the surgeon went in and actually found there was an adhesion or a connection of scar tissue between the hamstring tendon and the sciatic nerve. You really can't see the scar tissue very well on MRI, but intraoperatively, they will find that sometimes. So this is just a nice example of a deep gluteal syndrome. This is a patient of mine from years ago who presented to me with left-sided sciatic pain, and she already had imaging done. The lower back was okay, but she had some inflammation and a muscle tear in her outer hip area, and we'd call this trochanteric bursitis. You can see this white area. This is just inflammation or fluid. And my treatment plan for her was actually to do soft tissue work on the gluteal region, on the outer hip area, and I referred her to a physiatrist who did some trigger point injections, and she improved very well. So just an example of how locating the source of sciatic pain can be really informative to us as chiropractors as far as coming up with a treatment plan, figuring out where to treat the patient, and where do we apply our therapies. This is what we call hip spine syndrome. And it's a collection of four things. Number one, sciatic pain or radicular sciatic pain. And this is a patient who presented with lower back pain radiating down both legs, very classic type of sciatic pain that we would think of stenosis. And so just in these images here on image A, that's what we call a hip flexion contracture. He can't extend his hip very much. image B, that's showing hip arthritis, and C is showing what we call lumbar stenosis with a narrowing in the spine here where the nerves are coming down. They get a little bit pinched right here. And so if you have these three things shown plus the sciatic pain, we call that hip spine syndrome. And it's just an example of how many different factors can combine to produce sciatic symptoms. And you often wonder, if the patient didn't have hip arthritis, would he still have these symptoms? If he didn't have the stenosis, would he still have the symptoms? So if you take away one thing, sometimes that reduces the symptoms. So from a chiropractic standpoint, we try to address all these different things because it's all relevant to the patient's symptoms. This is what we call superior cluneal nerve entrapment with these three nerves up here that are emerging over the back of the iliac crest. And I just want to be clear, this group of nerves does not branch off of the sciatic nerve. However, when these nerves get injured in any way, maybe they get entrapped in these muscles here as they're coming through, maybe they get inflamed, it can trigger sciatic pain all the way down the leg. And the reason for that is they share the same nerve origins. And these ones are the middle or medial cluneal nerves, same thing. So this is important because it's been shown in some of the more recent studies that this disorder can be more prevalent in patients that have pain following spinal surgeries. And it's not to say that the spinal surgery caused this. I think a lot of people have this disorder going on leading up to the surgery just because they're in chronic pain, muscle spasms, and all that. But this is something I look for on a regular basis. And I think it's amenable to soft tissue work. I think it's amenable to certain pain medicine types of treatments that I do not do, such as injections. Sacroiliac joint problems can rarely cause sciatic pain. In my experience, it's not very frequent that it will produce a full-blown sciatic pain all the way down the leg. However, it does happen. Typically, these are patients with some kind of autoimmune arthritis, such as psoriatic arthritis, which likes to go after the sacroiliac joint. And the mechanism here is inflammatory mediators will build up in this joint as inflammation builds. The inflammation leaks out. It can go to this L5 nerve, it can go to these sacral nerves, and it can go to the lumbosacral trunk. And these nerves go down and they descend and they form into the sciatic nerve. And this is something I just threw in to keep in mind that we have to stay on our toes as chiropractors and be on the lookout for these very rare triggers of sciatic pain. But occasionally, patients will come in with endometriosis that is affecting the lumbosacral plexus. And endometriosis is just uterine tissue that's gone outside the uterus and it will bleed every month and create inflammation and pain. So the classic presentation of this is a female with sciatic pain every menstrual cycle that's gone on for years. And it does not really respond to the chiropractic care, but it's something that we refer out and we have to look for. And I like to mention the comorbidities in patients with sciatic pain because there's evidence that people that exercise more frequently actually have a better prognosis, and cardiovascular disease, diabetes, obesity actually worsens the prognosis for sciatic pain. Not only are you more likely to get degenerative changes in the spine and suffer from some aches and pains related to that, such as sciatic pain, but there's evidence that in people that have surgeries, they're more likely to have recurrent problems if they have comorbidities. And just some of the mechanisms here, let me go through. So cardiovascular disease, if you're having any kind of atherosclerosis or blood vessel calcification, such as shown in this image here, this is the aorta. There's actually little blood vessels that branch off of this and go into the disc. So that's how the disc gets its nutrition, its oxygen, its nutrients basically. And there's other arteries that come off called the radicular arteries and go to the nerve roots. And so the way I look at it is this: if you have a disc herniation, a disc injury, and you don't have the right kind of blood flow, it might not heal as well. That's just how I look at this. I have a very holistic viewpoint on these types of things. And then also stress. And there's one study on the top right here where they found that patients that reported high levels of stress actually had 3 times the odds of having sciatic pain. And it's super interesting. But the mechanism, I feel, is there's little connections between the sympathetic nervous system, which is the fight or flight system, and the nerves. And this should actually say L5, but basically these nerves come in, and the whole point of the sympathetic nervous system is to conserve energy and conserve blood flow to things like our organs and our heart and our brain. So the idea is that we get what we call vasoconstriction, or the blood vessels around these nerves or in the distribution of the sciatic nerve actually clamp down, and we're not getting the right circulation. And some people with sciatic pain actually say that their foot feels cold and things like that. So it is interesting. It's unclear if this is the exact mechanism, but I do think that stress plays a role. Let's go through the two most common causes for sciatic pain and how we distinguish between them. Disc herniation, LDH, that's typically in your younger patients. They feel better when they're standing, walking, or bending backwards. People with stenosis, they're typically older. They feel better sitting. They feel worse standing, and they feel better bending down. So very different sort of symptoms, although you can actually have both. And those are some of the toughest ones. If you have a little bit of congenital stenosis in your spine and your lower back and you're younger, you can get a disc herniation on top of that. And that is difficult. However, it's not out of the realm of treatment either. And then let's go through the intraspinal or the disc herniation and stenosis as a single category versus the gluteal conditions. So the deep gluteal syndromes, we recognize that by pressure on the glute will aggravate the sciatic pain. Like leaning to one side, patients always like to lean away from the pain when they're sitting. Typically gluteal stretches, piriformis stretches will aggravate those. And then compare that to the spinal conditions. There's typically some kind of relief with flexion or extension of the lower back. So there's some overlap with the pain patterns. It can be tough to tell, but we use this sort of distinctions to tell between them as best we can. As far as the evidence base for chiropractic care or spinal manipulation for conditions in general, the bulk of the evidence in our profession is linked to conditions of the spine or musculoskeletal conditions. And that's important because a lot of our training actually goes into spine related disorders, and that tends to be the most common things that we see in our practice. There was a large study that came out a few years ago called a meta-analysis where they looked at 122 studies for sciatic pain, and they rated them according to whether or not the treatment worked and there was success or a treatment failure. And spinal manipulation, which is one of the common tools that we use as chiropractors, was one of the most effective tools. And patients that received spinal manipulation had almost 5 times the odds of improving or having success with their treatment. And right actually above that is acupuncture, which is a great tool. We have acupuncturists here in our department here. And if you look at bed rest, that's way down. I mean, the bed rest used to be one of the most common treatments for sciatic pain, and now it's not, just because the evidence isn't really supporting it. And I interpret this study with a little bit of caution, though, because it is 5 years old, and there's been a number of studies that came out since. And I think that things like exercise and traction might be a little better supported in this. So let me proceed here. This is one study that's come out since that study was done. It was done in Switzerland, where they have an integrative medical chiropractic school. And they compared patients receiving nerve root injections, epidural injections, to those receiving spinal manipulations. And patients reported similar outcomes in both groups. And this study helps to show that chiropractic spinal manipulation is a viable option for patients suffering from sciatic pain. It's not exactly what we see in practice, because patients don't have to decide one or the other. They can actually do both. And that's what a lot of our patients do. They're seeing pain medicine, physiatry, and they're seeing us at the same time, which I think is synergistic. Another benefit of patients receiving chiropractic care is they're less likely to receive an opioid medication. Number one, I mean, we do not prescribe as chiropractors. Number two, it might just be that patients choose us that are more naturally inclined. However, a large study was done, and yes, they're less likely to get opioids. Different guidelines are out there, different research studies are out there as far as how long should we treat a patient with sciatic pain as a chiropractor. And my rule of thumb is we should see some kind of relief within 5 visits or so. I mean, if a patient's not responding at all, then we tend to think of other options. However, it really depends. Sciatic pain is on a spectrum. And in some patients, they just have pain and that's all they have. In other patients, they have weakness and what we call motor deficits. They might have bladder issues, bowel issues, and those are more red flags that warrant either urgent spinal surgery referral or more of just a consult. However, in the patients that don't have those red flags, we can treat them for 2 months or more comfortably without worrying about things getting worse. Adverse effects of spinal manipulation are very rare. There was a study done, a couple studies where they found only a handful of cases where patients with disc herniations had worsening after spinal manipulation. And we use a lot of precautions in these patients anyways, even though it is safe what we're doing. If a patient can't tolerate lying down on the table, they can't tolerate rolling over, I mean, we're just going to be very, very gentle starting off, and we'll use soft tissue work and we'll focus more on the stretches, the exercises. And we just kind of build our treatment plan around each patient and go to their level of tolerance with the treatment. This image depicts probably the most classic thought of spinal manipulation procedure that we do, what we call the spinal side posture manipulation. And we will do this on some patients with sciatic pain, particularly those with lower back related sciatic pain. However, it can be too much for certain people and we might skip it. We might just have them go face down or lie in a way that's comfortable for them and focus more on some soft tissue work. This is what we call flexion distraction. It's a technique that combines traction with mobilization of the spine and movement of the legs. And it helps to open up the space between the vertebrae. And if you have a disc issue, if you have stenosis, this would be for you. Thoracic spine. So when we have a patient with a lower back related sciatic pain, we actually work above that area. We actually go into the thoracic spine and we work below that area. So the whole idea with this is that we're trying to improve mobility across the spine so that there's not as much stress just on that one spot that's affecting the patient in the lower back. Exercise is something that we often do for patients. We give them things like this. This is a side plank. This patient has a little bit of instability in his lower back, as you can see right here with this facet joint gap. It shouldn't be gapped out that far. He also has a disc bulge. He had some pain down the left leg. And so when we notice this instability on the imaging or with his symptoms, we give patients spinal stability exercises. And if you notice, he's actually on his knees here and not all the way on his feet. So I like to start people with the basic side plank on the knee. This is another favorite exercise of mine. We call this the anti-rotational press. And I'm not twisting, I'm actually just pushing in and out front and back. And the band is trying to twist me and I'm trying not to get twisted. What this does is it stimulates the multifidus muscle. The multifidus is the deep muscle right near the spine. It stabilizes the spine against small twisting injuries, things like that. It's a great muscle to protect the spine against disc problems. It's a really good exercise to give your golfers, baseball players, hit any type of volleyball, overhead, hitting athlete, anything like that. You can work the non-dominant side with this too. This is the bird dog. And I like this because there's no, what we call axial loading. There's no compression on the spine. Everything is horizontal, so it's just very gentle. In image A, you're just lifting the arm, B, just the leg, and then C, you actually is the most difficult variation of the bird dog. You're doing one arm and one leg. I like to progress people through this slowly. If they can handle C from the get-go, we'll do that. But if people are wobbling and they can't stabilize or they're compensating, we just start with A or B. Directional preference exercises. This is actually just as much an examination as it is a treatment modality. We run people through a movement screen and see what feels good. And if any one of these positions alleviates their sciatic pain, we typically give that to them as an exercise. So your younger patients with disc herniations typically will feel better with these extended postures where they're leaning back. And typically older patients with lumbar stenosis will feel better with these flexion exercises. And we'll have people do this every couple hours through the day if they're motivated to do so, if it's helping them. This is an example of a flexion stretch that I gave a gentleman with lumbar stenosis. And he had some motor deficits, some pain. He wasn't ready to try surgery. So we gave him these stretches alongside his treatment. It really helped him out. He was able to get back and play golf. We call this flexion and step standing. It's one of my favorite stretches for stenosis because you can do it anywhere. It's easy to do. Just prop your foot up on a bench or a chair and lean down. Dry needling is one of my favorite treatment tools for sciatic pain. It's a technique of inserting a thin monofilament needle into a muscle in order to get the muscle to relax out of a spasm. And it's a little different than acupuncture. Acupuncture is a more holistic service that focuses on the whole body, and it's also diagnostic and treatment. However, dry needling is much more localized to the area of pain. It's a little more simplified. It has more of a biomedical, anatomical approach to things. And so I do not do acupuncture. We have acupuncturists, and I think acupuncture is great for sciatic pain. And we have people that are awesome at that in our department. However, this is what I do. I do some dry needling. Um, Really awesome for not only low back related sciatic pain, disc herniation, stenosis, but it's also good for things like piriformis, deep gluteal syndrome. And there's been a couple of randomized controlled trials that have come out supporting this in the past few years. Traction is another excellent tool for patients with what we call discogenic sciatic pain or sciatic pain related to the disc. It doesn't work for everybody. And I like to caution people with this though, and recommend that they don't go fully upside down right away. I actually like to go and lock the inversion table about halfway. So they're just getting a little bit of traction. The other thing you can do is you can hang from a pull-up bar if you're strong enough to do so. Just 10 seconds, 30 seconds, a few times a day. There was a randomized trial on that showed it gave people a lot of relief. Supplements for sciatic pain. So there's no magic pill. However, these are probably the most evidence-based supplements for sciatic pain. My favorite one to give most people here is palmitoyl ethanolamide. It's an anti-inflammatory. It's a lipid-based or a fatty molecule that was developed or discovered from egg yolks. And it goes into the nerve and it stops what we call neurogenic inflammation. And it does not thin the blood. And to date, there are no reported side effects from this. And there's been a handful of studies on it used for sciatic pain. I like to test people sometimes for vitamin D, vitamin B12, vitamin D. A lot of people are low in that at this latitude or higher in the fall, winter, and spring. And when we see deficiencies in vitamin D, people tend to get hypersensitivity in their muscles. Low B12 is a trigger of numbness and tingling in the legs and the hands. It's another common deficiency as well. So it's worth getting checked sometimes in some of these patients that have chronic sciatic symptoms and they seem not to be responding as well. It's nice to check and then deliver these supplements to them. So, how does spinal manipulation work? And there's a lot of different theories. Probably the oldest theory amongst the one I'll discuss is spinal mobility. So, there's this concept that we are working as chiropractors on areas of the spine that are stiffer or what we call hypomobile. And the common example is the middle back or the thoracic spine. And this is incredibly important for people with lower back related sciatica, especially people with what we call spondylolisthesis or a slip bone. And there was a study where they actually did thoracic spine manipulation on, oh, it's right here, where they did thoracic spine manipulation on patients with spondylolisthesis and got great results. It hasn't been repeated, so interpret that with caution, but that is something that we do all the time. When you manipulate someone's spine, there's the cracking, there's the popping, and a lot of times a patient with sciatic pain will be able to bend down further. You'll be able to lift their leg a little bit higher. And the ideas as to what is happening there and to why that's happening is maybe we are breaking up adhesions, maybe we're getting the muscles to relax, maybe we are just reducing the pain response enough so they can move. This brings up the idea of what we call the neurophysiological explanation to spinal manipulation. This is a picture of the spinal cord, and I show this because it's a common theme amongst research in manual therapy that what we call mechanoreception or mechanical touch or pressure or any kind of mechanical sensation that sensation travels up the spinal cord and it goes to this area called the dorsal horn of the spinal cord right here. And that sensation can actually block pain. There's other channels, what we call nociceptive circuits in the spinal cord, and the pressure or touch or mechanical sensation can actually block the nociceptive sensation. So some people say, okay, maybe we're just distracting them from the pain, putting in one sensation in the body, blocking another. And yes, that's sort of what's happening. And I think all these mechanisms are at play. I don't think it's just one or the other. I think they're all a little bit involved. And I do like this one. This is an interesting study. They actually took patients that were healthy and they had them lie down in an MRI scanner. And the top image is just at rest, and the bottom image is immediately following a spinal manipulation, the side posture manipulation that I showed. And the joint actually gaps a little bit. There's a little bit of an opening there. And that's what makes the popping noise, actually. So when the joint gaps open, there's little bubbles that pop out. The idea here is maybe we are opening the joints just enough so that the patient can get moving again. This is a newer study that hasn't quite been repeated, but I like to show it just because it's super interesting. On the top, we see the asymmetrical intensity of the psoas muscle. And the psoas muscle is your major hip flexor group. It's the tenderloin. And you can see it's dark here, it's light here. And then this is following spinal manipulation. It evens out. There's been other studies where they do surface electromyography, and they find that the increased resting activity of the muscles is calmed or reduced following spinal manipulation. So we're getting the muscles to relax, we're getting things to loosen up, and that'll help the patient be pain-free and move. There's this other concept that when we manipulate a person's spine with spinal manipulation, with sciatic pain, we are helping circulate fluid around the nerve. And this is another newer study. Hasn't been a lot of other studies similar to this, so interpret it with caution. But this white fluid here is the cerebrospinal fluid, and more of it is flowing around the nerve following the spinal manipulation. This is before. And the other interesting thing about spinal manipulation is we're not immediately changing the position of the bones necessarily, the shape of the disc herniation, the size of the disc herniation. All of that can stay constant. We are working more with the physiology, the biomechanics, the circulation. We're getting things to feel better, to move better. It's not necessarily about position. However, one kind of exception to that is traction. When you traction a patient, the space between the vertebrae can actually separate a little bit. In this one study, they hooked people up to water bottles in a MRI machine and literally stretched them apart. And what we find is that there's a little bit of a gapping between the vertebrae here. And the disc is osmotic. It's like a sponge. It's filled with sodium and other electrolytes. And when you stretch the spine, it actually absorbs water, which is great. And that's why you're a little taller when you wake up. And so we incorporate traction in the flexion distraction with the hanging from the pull-up bar, hanging upside down, all those different things. One point is traction probably doesn't work for everybody, even in those with disc herniations. I think personally, just looking at the research, it might only work for what we call central disc herniations, including protrusions. If disc herniation is completely broken off of the spine and it's separate, what we call an extrusion or a sequestration, traction might not really do a whole lot for that, but it usually doesn't hurt people to try. The mechanism is when you stretch the spine out, this ligament gets very tight and it kind of pushes forwards on the disc. This is what we call Gunn's radiculopathic model, and he's a medical doctor and acupuncturist who theorized that when we have muscle spasms alongside the spine, it actually compresses the disc. And really interesting theory, because some of the other biomechanists have done calculations where even just the psoas muscle can put 50 to 100 pounds of compression on the spine when it's contracting. So I think that there's some research to back that up. And this is one of the explanations as to how dry needling works, where if you are able to put the needle in a muscle, it can relax and go from this to this, and then reduce the compression on the disc. Another mechanism of dry needling, potentially acupuncture, When we insert the needle, it sends that mechanical stimulation, which goes into the dorsal horn of the spinal cord and can block not only the pain, but it can block what we call the alpha motor neuron, which goes to the blood vessels. And we get this vasodilation response. And whatever clamping effect that the sympathetic nervous system was having on the blood vessels is sort of reversed, at least temporarily. And patients will get more blood flow, or what we call vasodilation, in the leg. After we dry needle, some people feel like a rush of warmth going through their back, through their leg. And this potentially could be one explanation, is what we call vasodilation. Taping, kinesiotaping, is a tool that I've found to be somewhat helpful. In particular, patients with instability or connective tissue disorders, it provides a sense of comfort or compression or squeezing on the spine that can block pain. As far as choosing different treatments, I think that there's more synergy than we typically appreciate for different treatments. This is an older study, but what they found was patients that were receiving different types of therapies actually got better faster. And this is what I see in my own practice. So we combine chiropractic with physical therapy with medical, and I think it actually helps people that much more. I like to show this image. This is a recent study on patients with no pain at all, and how common are things like disc bulges. Well, it turns out whatever decade of life you're in, that's the percentage of people that have a disc bulge, basically. So if you're in your sixth decade of life, 60%, decade of life, 50% will have a disc bulge. And I show this sometimes to patients in an educational light and try to help people and be optimistic, because some people feel like they're falling apart, there's wear and tear and everything's breaking down, where it turns out it's actually somewhat normal to get what we call degenerative changes in the spine. There's really not a whole lot of difference between aging and degenerative changes in the spine. Some people will get those earlier than others, and that's unfortunate, but by and large, everyone gets these things. So it's not all bad. When we look at an MRI, oftentimes we're looking for the disc injuries, the spinal stenosis, but there's other things. And this isn't why we get an MRI, but if you have one, you might as well look. What we're looking at here are the muscles of the lower back. And these are two ex-college football players. This patient has larger muscles without any atrophy. And this patient has atrophy of the multifidus. This is letter T, and atrophy of the erector spinae, letter E. And so that's super important, because when we see atrophy of those muscles, we really want to do the bird dogs, the anti-rotational press, the side planks, things like that. Maybe even refer to physical therapy for a lot of these patients if they have a lot of atrophy, and get them doing even more in-depth exercises than those. Atrophy of the muscles is an independent predictor of leg pain in patients with sciatic pain or disc issues. So it's very, very important. There's a theory that there is this subtle shifting in the spine that irritates the nerves when there's atrophy. What do we do with patients that have had laminectomies, discectomies, fusions, all that stuff? We actually work on patients that have these regularly. I mean, almost every day. And there are certain precautions that we need to take. We are not pushing directly on a fusion, but we might work in the thoracic spine. We might work on the hips. We might stretch the patient, do soft tissue work. There are a lot of options as to what we can do. And in patients like this, sometimes it's not about getting them to be pain-free. Sometimes it's about bringing them from a 9 out of 10 to a 6 out of 10. And people have to work with their other medical providers to get even further. We can also work on patients following injections, trigger point injections, epidurals, nerve root blocks, all that stuff. Typically, we don't work on patients that had an injection that day, although usually that's just a scheduling reason. There's been a number of studies on manipulation of the spine following injections, and these studies didn't find any adverse effect of that. But typically, I tell people get in the next day, 2 days later, try and get in the same week. There's this idea that if you inhibit a person's pain, you get them out of inflammation, you get their pain levels knocked down a little bit. We can, as chiropractors, actually do more with that patient. We can stretch them a little further. We can do different exercises with them that we wouldn't normally be able to do. So it's a great way to break through a plateau in a treatment of sciatic pain. And then I like to show this graph. This is just the prevalence of sciatica in different age groups. And sciatica is actually a disease of younger people from the mid 30s to mid 50s. It actually goes away with aging. And despite that, the degenerative changes in the spine increase steadily as you age. So this is one example that it's not necessarily directly correlated to all those changes. And it's also a reminder for patients that feel kind of doomed that if they have a disc herniation, it's stuck with them the rest of their life. It's really not true. Not only do the majority of those, or 2/3 of those disc herniations shrink, but with aging, sciatica is less common. And part of the reason for that is the fluid in the disc will dry out. It goes from sort of a grape to a raisin in that sense, and there's less fluid in the disc. That fluid can be very inflammatory. So some of the degenerative changes are, in a way, almost protective of sciatic pain. And then these things I like to just repeat to patients almost like mantras. 75% of patients will be much better in 3 months. Only 5% require surgery, and doesn't mean you're going to have this the rest of your life. So I try to be optimistic with people, even though we're seeing sometimes patients that have had this for months or years. We do what we can, and most of patients will improve. And this is our team. We have a excellent integrative team with acupuncture, massage, integrative medicine. And I'm really, really happy to be here at Connor Integrative Health Network. Very, very happy. If you have any questions, you can reach out to our department, or you can reach out to me, and that's my email. And yeah, feel free to ask any questions.
Yes, thank you so much, Dr. Traeger, for that presentation. We do have some great questions that have come in throughout. We're going to start with a couple questions that came in actually before the presentation. The first of those being, what is the frequency of sciatica that's being caused by lumbar disc joint myofascial pain syndrome and stenosis in different age categories?
Yeah, it's a great question. So the younger people under 50, those are most often disc related, and the older people, those are over 60, more often stenosis. However, in both categories, you can have myofascial conditions, you can have deep gluteal syndrome.
Okay, good to know. And then, can we prevent stenosis or neurogenic claudication? Hope I'm saying that right, from occurring?
Yes. So neurogenic claudication is the symptom of radiating pain into your legs that's linked to lumbar stenosis. It happens with walking. It's relieved by sitting or flexing. And if you already have neurogenic claudication or pain down your legs related to stenosis, you can do what we call flexion-based exercises. Hugging your knees to your chest often works, not always, but see a chiropractor, see a physical therapist, see your primary care, maybe another specialist to get treatment. But as far as preventing it from coming on in the first place, taking care of your overall health is probably the most important thing, because there are links to metabolic disease and stenosis. Some people are a little more predisposed to stenosis, and that's something that we cannot necessarily control, but we do the best that we can.
Someone has asked whether or not Medicare would cover chiropractic care.
Medicare covers manipulation of the spine. So in most cases, sciatica is spine related. So probably yes. The one caveat, they do not cover the initial exam, but you can call the office and you can call your insurance and you can ask them more questions.
Fantastic. We have someone who was diagnosed with sciatic pain that was caused by a rotated pelvis. They received 6 weeks of chiropractic treatment as well as physical therapy, but they don't feel they've improved and seem to be getting worse. They wonder what the next steps might be.
Okay. Yeah, 6 weeks of therapy is enough of a trial of care that in these patients where they've had sciatic pain and they're going through a month or two of therapy, at that point, it might be nice to look at some imaging, to get another evaluation and maybe get another opinion, see what's going on. The rotated pelvis, I mean, that does happen. I mean, but it makes me wonder, in general, when I hear things like that, I wonder if something else is going on. It's not on the number one cause list of sciatic pain in my head. So maybe get a more thorough eval. It would be my kind of recommendation for patients with ongoing symptoms that's not responding.
Okay. Great. Um, we have a question from someone who was receiving chiropractic treatment earlier this year, and they found that as a result, their condition completely went away. They wonder, should they be concerned that the condition might return?
Okay, so that's great. I mean, I wouldn't be necessarily concerned, but I would be proactive and keeping your muscles strong, staying active, taking care of your health. And these are things that we should all do anyways. There is some recurrence with disc herniations with sciatic pain. I mean, it does come back in some cases, but I think once you get to the point where you're feeling good, it doesn't necessarily just come back just all of a sudden. So that's great.
Awesome. Okay, so now getting into the questions that came in during the presentation. We'll get to as many as we can, so thank you very much, everyone. Um, so someone has asked what the difference is between chiropractic treatment and physical therapy when you would refer to one versus the other.
So, and this is just my perspective, and I've worked with a physical therapist for 6 years, and now I'm in an integrative setting as well at the hospital. I feel that it doesn't necessarily matter too much. I mean, you can refer to both. However, we focus more as chiropractors, I believe, at least in the hospital network, more on pain relief. I mean, we do the dry needling, we do the soft tissue work, the manipulations, we'll do a little bit of rehabilitation. Now, if someone has their pain levels calm down and they're able to do more, maybe physical therapy might be a better answer, although you could really go either way. And I think the best kind of patient-centered answer is you kind of give a patient a rundown and let them choose would be one option as well.
Fantastic. Someone has asked if they can use, or if you would recommend an inversion table to help with stenosis.
So sometimes it helps, sometimes it does not. I mean, the one caveat to inversion tables for stenosis is you're lying flat, and some people with stenosis do not like to be completely straight. They like to be kind of bent. So it can help, it can aggravate it. So also maybe just try it out first before you go and buy one, if that makes sense.
Has asked whether or not pelvic tilt exercises are valuable. They mentioned they used to get relief when doing them, but not so much anymore.
Yeah, I actually really like pelvic tilts. I think it's a great way to get the muscles working and it gives a little bit of mobility as well. Um, if you're trying pelvic tilts and they're not working as well as you'd want, I mean, it would really maybe be a good idea to get another evaluation and see if there's other stuff that you could do.
Okay. Let's see. Someone who's asked about how to be referred. Does chiropractic care require referral from a primary care physician to get started?
So it doesn't require a referral. A patient can just call and make an appointment. However, sometimes it facilitates the process. If you go in the electronic medical record, you can order a referral for chiropractic. Usually just put evaluate and treat on there unless you have something very specific that you're looking for. And if you like to write up a little memo, you can, but if you're internal to UH, we can see your records. That's one of the beautiful things about being here. We can see the images, we can see everything that's going on, the medications, which is great.
Awesome. Someone has asked how sugar may contribute to inflammation. They specifically ask about drinking wine and whether that might contribute to any inflammation associated with sciatic pain.
Yeah, I think that's a great question. I think that in general, right now, we have a problem in our society with metabolic syndrome, diabetes, and sugar is basically to blame for a lot of that. And in particular, regards to sciatic pain, there's a linkage between sugar or diabetes and degenerative disc changes. There's a link between sugar and thickening of the ligamentum flavum. And there's actually a new study that came out where they did a little biopsy on the ligamentum flavum and found that there's actual sugar in that. So the theory is that the sugar gets in there and actually absorbs water and sort of thickens. So that is potentially one of the triggers of stenosis. So I think it's very pertinent. I think that people need to work with their primary care and maybe other nutritional coaches to try to watch their sugar intake. I think that's a really, really great, pertinent question.
I agree for sure. Someone has asked, said they have a lot of numbness that they experience along with their pain and wonder if this will ever go away.
So sometimes when people have a really severe neurological deficit, numbness, even once the pain gets better, once the disc heals up, sometimes that lingers for a long time. And it's tough to say if it will completely or not. I think it's a very individual kind of question. And I think the biggest thing is for people to sort of get looked at and say, are they better and just waiting for that nerve to heal, which takes time, or is there still room for improvement overall, if that makes sense?
See, another nutrition-based question. So this may have been partially answered with the sugar question from someone who's been diagnosed with oh my goodness. So sorry, spondylolisthesis. Uh,
Spondylolisthesis. Okay.
okay, there you go. And if there are any nutrition choices that might help improve the condition.
So yeah, so usually with a spondylolisthesis, there's two kinds. There's a stress fracture, which happens in younger people. Then there's the degenerative spondylolisthesis, which is usually a forward slipping of the vertebrae with degeneration of the spine. I think the biggest thing with that, and this is an underappreciated point of view, is that keeping your bone density up is actually really, really great. Get your vitamin D looked at in most cases, and that's why I put that on the slideshow. There's another vitamin K2, which is good for your bone density. The only caveat with that, you have to ask your primary care because it does interact with blood thinners and like warfarin. So keeping the bone density upright and maybe do your exercises, things like that.
Okay, fantastic. We're getting close to the end here. We'll do just a couple more quick questions. To any questions we don't get to, we will do our best to follow up afterwards via email and review any that we don't fully get to. Someone has asked about exercising on their own and whether you might recommend exercising in water versus on land or a more traditional exercise.
Yeah, so patients with disc-related sciatica, lumbar stenosis, they tend to love the aquatic therapy. I think it's absolutely awesome. When you're in the water, it's sort of buoyant. There's no compressive loading on the spine. It's a great way to get started. I think that's perfect.
Wonderful. Can you clarify which locations you see patients at? Actually, we have it right here on the slide to that attendee.
Okay.
You see people at
Yeah,
Rocky River and Parma.
so I'm currently in Rocky River right now, and twice a week I'm in Parma Community Hospital.
Perfect. All right. I think this will be our last question. Can you explain the difference between chiropractic care and mechanotherapy, or are they considered the same?
Mechanotherapy, I'm not really sure kind of what the question is referring to, but maybe any manual therapy, I suppose, has some similarities. We do use our hands. I mean, so massage, there's some overlap between all these different hands-on therapies or manual therapies. So I think that when you see a chiropractor, we emphasize the diagnostic process, the assessment. We're looking at imaging, we're coming up with a plan, referring to other doctors. And we even have massage therapists in our office that we work with that are awesome. And sometimes we will refer patients to them too. So it's all valuable. It just depends on what each patient needs.
Wonderful. And very quick, I wonder, we've had a couple of requests to go back to the picture of that shows the whole Connor team. Is it
Okay.
possible? There we go. So thank you to our attendees who asked that question. This is our fantastic Connor team. And that does take us up to the end of time here. So again, thank you everyone for those fantastic questions. And thank you, Dr. Traeger, for your time and for sharing this information.
Thank you,
Just a couple,
everybody.
thank you. And a couple of very quick reminders is that for anyone who attended today and was registered for the webinar, you will receive an email with a link to the recording once that's posted, usually within a week or so. So if you wish to go back and review any of this information, you are encouraged to do so. And to schedule an appointment with Dr. Traeger or any other provider in the Connor Integrative Health Network, you can reach us at 216-285-4070. So that concludes our session. Thank you so much, everyone, and have a great rest of your day.